I just want to thank Justin and the pain team for inviting me to come and talk to you this afternoon. As Justin said, I'm an enhanced recovery nurse at Salford Royal. I've actually been there for 27 years and most of my career has been in surgery. Prior to enhanced recovery, I worked in our pre-op clinic for 10 years, so I've got quite a lot of experience in surgery. This is Salford Royal, as you've all seen from various pictures, that we've all had the same one. My aim for this afternoon really is for you to get a little knowledge of the history of enhanced recovery, what our pathway looks like and the pathway that the patients follow, what my job is on a daily basis, what I do with our patients. I'm going to put a little bit about pain management in there and what we do with our patients. And as Dr. Turner said, I'm going to share some data of ours with you. And at the very end, thankfully, I've got a video, a little DVD to show you, because I can stand up here all day and tell you how fabulous enhanced recovery is. Excuse me, my voice is going a bit. But it's about our patients, and there's 3 patients from 3 different hospitals, and they'll tell you, thankfully, how good enhanced recovery is, because it's all positive. So, enhanced recovery was started by this guy here, Henrik Kellett, who was a colorectal surgeon, and he noticed that his patients were in hospital for an awful long time. I think his length of stay was 15 to 20 days. And he decided that really it was too long for his patients to be in hospital and they were getting post-op problems. He changed his practice dramatically, which I'll go through with you in a little while, and managed to reduce his length of stay to 4 days. And these patients were all having laparotomy, so it was before the days of laparoscopic surgery, and he was getting his patients home in 4 days. Here is the benefit of enhanced recovery. The gentleman on the left that you can see is the patients that I remember 10 years ago. Flat in bed, nasogastric tube, nil by mouth, looking pretty sick really. That's our gentleman 12 months ago, sitting up in our surgical high dependency, first morning after his operation, smiling for Mr. Slade, having a cup of tea. He has got an epidural running there at the side, you can see. He was out of bed that morning and home on day 5. I know which I'd rather be of those two patients. So traditionally, what did we do? I certainly, and Alison, because we trained together, remember what we used to do with our surgical patients. So we dehydrated them because we gave them loads of bowel prep. We brought them in hospital 2 days before their operation. They got 4 litres of bowel prep, and poor souls were on the toilet for 2 days. They went to theatre and the anaesthetist then drowned them with loads of IV fluids, and they got loads of IV fluids after their operations as well. These people were stressed. We thought the analgesia that we used at the time was brilliant, but it wasn't. And the patients, although they were counselled, because we did have colorectal nurses, they didn't get the level of counselling that they certainly get now. Whilst they were having their bowel prep, they didn't eat. So for 2 days before their operation, they were starved. Post-op, first 24, 48 hours, they were lucky if they got 30 mils of water an hour. By day 4, hopefully they were on soup and sweet and in hospital for 14 days. Although I've put admitted day before surgery there, they actually came in 2 days before, so we already had an extended length of stay of 2 days because we were giving them bowel prep. So the effects of enhanced recovery for our patients now, we reduce their stress, they feel better because you can see how well that man looked. From a trust point of view, from a management point of view, it does reduce length of stay, and I'll tell you a bit about our length of stay data later on. It reduces post-op morbidity because we get them up and get them going straight away, and they get an increased focused input from me because that's what I do every day, which I'm going to talk to you about in a few minutes. Not like that's a benefit for the patients, but that's what I do. So the Enhanced Recovery Partnership put together this document which we followed when writing our pathway. And it starts from patients' referral from their GP right through to them going home, and practice was changed at all elements along the way. So they went to pre-op, they had a full pre-op assessment. We started to bring the patients in on the day of their operation. We don't give them bowel prep anymore, we give them carbohydrate loading. Most of our patients now have laparoscopic surgery, as you heard Dr. Turner say. We don't do many laparotomies anymore. It's rare that our patients come back to surgical high dependency with a nasogastric tube. They might have it in theatre, but they take it out at the end of the procedure. some of the anaesthetists use goal-directed therapy. Can't tell you a lot about that. That's probably their bag to tell you, but they do use goal-directed therapy. Once the patients are back on the ward, we get them up, get them going. Regular analgesia, it's the key. At the end of this, pain relief is key to the whole enhanced recovery, and I'll go through that in a few minutes. And the patients are well supported when they go home. Initially, enhanced recovery was devised by Keller, and he was a colorectal surgeon, and we've been doing enhanced recovery with our colorectal patients for the last 4 years. 2 years ago, we were given some monies from the Cancer Network, and because we were already doing it with our colorectal patients, Mr. Slade suggested that it might be good if the urology patients came on board, and along with urology, somehow gynae came along as well. So all our urology and gynae oncology patients now go through our enhanced recovery programme, along with orthopaedic patients, and soon upper GI patients will be on enhanced recovery programme as well. Thankfully, we have a dedicated urology enhanced recovery nurse. They're about to employ a orthopaedic enhanced recovery nurse and an upper GI nurse as well, so there'll be 4 of us, which we are very lucky because lots of trusts don't have anybody doing what I do. Nationally, some trusts have developed an enhanced recovery programme for emergency surgery, medicine, and even for transplant patients. So they've taken the core principles of what we use in colorectal and developed it for other specialities. Enhanced recovery isn't just about me and what I do. As Alison showed you, the pain team here, I guess this is my team. We couldn't do enhanced recovery without everybody being on board and everybody being focused in getting the pathway running properly. So these are some of our surgeons. You can see the pain team at the top there with, I think it's Dr. Turner and Dr. Makin. Ward staff, and I'm conscious that one of our physios is in the room here, and she isn't on that picture, probably because she wasn't around when Mr. Slade was taking these photographs, but we certainly couldn't do enhanced recovery without our physios as well. When I first came into post, the first job I had to do was write an enhanced recovery pathway. I wanted it to be a user-friendly document, and all the people in the slide previously were involved in their little bits, so the pain team had input, the physios had input, the dietitians had input, and the nursing staff on the ward had a massive input. They were the ones that were going to be using this document, and this document follows the patients from pre-op when I see them to discharge, and all their care is documented in this pathway, as well as the core things for nurses, so pressure area care, hygiene care, so that the nurses were only using one document. And although, as Alison mentioned earlier, a lot of our care plans are electronic, the nurses do write in this document. Having said that, if a patient becomes unwell, if they develop an ileus, we will take them off the pathway and revert to normal nursing care plans. So as was mentioned earlier, it's essential that the patient understands what they're coming in hospital for, and we want to change their expectations of what hospital is now. I pre-op patients who have had a neighbour that have had a bowel resection 5 years ago, and they were in hospital for 14 days. Love, it'll be all right because I'll be in for 14 days. And when I say to them, you're probably looking at 4 to 7 days, they're a bit aghast. But when I explain to them what we do and how we help them get better, they don't want to be in hospital, they want to be at home and they want to get better in their own environment. So I spend a lot of time with them in the pre-op clinic going through what enhanced recovery is. I'm just going to give you a little bit of an idea now of my role with the patients from pre-op really. So I meet them in our pre-op clinic and we run a one-stop service really. So patient goes to our outpatients clinic, they see the consultant, surgery is discussed with them, and they go straight round to pre-op where they have an anaesthetic assessment with one of the nurses. And then I spend about 35 to 40 minutes with the patients, explain to them what enhanced recovery is and why we're doing it. All our patients, unless they're diabetic, get carbohydrate loading. I talk to them about pain relief, so in depth I talk to them about whether they're going to get an epidural, a PCA, and I'll go through that with you in a little while. As was mentioned earlier, pain referral is key really. If I've met a patient who's had surgery in the past and had, in their opinion, their pain wasn't managed very well, do an automatic referral, usually Miser Martin, and say, I've got a Mrs. So-and-so coming in a few weeks, and they're aware of those patients then, and they look out for them when they come in. As Dr. Turner mentioned, the majority of our patients do have either a central line or an arterial line. And so I explain to the patients about that and why we have them in, just so that they're not frightened when they wake up and think, oh God, what have they done to me? It must have all gone wrong. They all go to surgical high dependency, even the patients who have PCAs, because that's where the bed's booked, and they generally just go straight there, although very occasionally we can get them onto the ward. I do try and show the patients around surgical high dependency, particularly those ones who've never been in our hospital or have never been in a high dependency, just so that they can meet some of the staff up there and realise that it isn't a daunting place. It's actually in that new building that I showed you at the front, and it's actually quite a stunning place to go. So when they get up there, they're quite happy that, well, I don't mind coming in here, it'll be okay. I explain to them the difference between high dependency and the ward, because high dependency, it's 1 to 2. When they get on the ward, it's 1 to 7 or 8, depending on which bay you're in. And I need the patients to understand that, yes, when you're on high dependency, you'll get a high level of nursing input. When you get down on the ward, you're obviously got a little bit better, and you're going to need less input, just so that they don't get, because some of them do get stressed that, oh, I had a nurse on tap and now I haven't, and it's all going wrong. And at pre-op, we talk about going home. And I know that sounds a bit, oh God, talking about going home and I've not even got in yet. But we have had delayed discharges because although a patient could tell me at pre-op, well, I've got nobody to go home to and I want to go into some sort of respite care afterwards, I have, up to about 3 months ago, I had no way of referring them onto the social worker. So we had one lady come in, ready on day 4, was with us for 10 days because she needed to go somewhere, and it took social services all that time to sort her out. So I try really hard now at pre-op to identify that and refer on to our social workers. And we've got an agreement that I can do that to smooth the pathway so that we're not keeping these patients in for 10 days longer than is absolutely necessary. Once the patient's had their surgery, they probably get sick of the sight of me, to be honest, because I go round on the ward round in the morning just to make sure that they're well and they are able to eat and drink like we've told them they can. And also to remind the doctors what we should be doing, and can we get this catheter out, and can we stop these IV fluids. So we try and stop their IV fluids the next morning because they are eating and drinking straight away. That's our plan. One of my consultants refers to me as the nurse with a stick because he says that Rachel will be behind you, beating you down the ward to get you going. I don't do that. I very much, it is very much a partnership and agreement. So if a patient knows they've got to get out of bed and got to walk 4 times a day, if I go and they say, Rachel, I don't want to do it, I can't force them. And I'll tell you that to them, it's about you getting better. One patient has said to me that he realised that the process of getting better, 70% is what we do as medical staff and nursing, how we help them get better. But actually, he said that 30% of his getting better was himself. He said, I knew that I had to get out of bed and I had to get going, because if I didn't, I'd never get better. And I've taken that on board, and I've actually said that to a few patients now, just so that they realise that it isn't all about us making them better. It's about them helping themselves get better. And he also spend a lot of time with the staff, particularly when we get changes of medical staff or new nursing staff, that they understand what the pathway is and they understand what we're aiming to achieve. And again, discharge, we look at it every single day. As I mentioned earlier, mobilisation is one of the key things for our patients. So we expect them to be up and out of bed within 6 hours of surgery. Realistically, we don't achieve that. It is the next day. But if they're not comfortable, they're not going to get out of bed. And if they're not comfortable, they're not going to walk 4 times a day, which is what we're expecting of them. Now, the enhanced recovery literature talks about 60 metres 4 times a day. And I measured that, and it was a long way. It was further than I would expect them to walk. So I had an agreement with Danielle, our physio at the back there, just for them to walk 4 times a day. And if that's bed to chair or bed to the neighbouring bed, it's better that they do those 4 walks than 1 long walk, get back to the bed and think, I ain't doing that again today. You can forget it. We like them to be out of bed for 6 hours. And for some people who've had a laparotomy, and I'm telling them this at pre-op, and they're thinking, she's mad. How can I possibly get out of bed? I'm going to have a big cut in my tummy. But it's surprising when they have good pain relief that they do it. That's the key. I can't stress how important it is for my job that if these patients get good pain relief, they will achieve everything that we're asking them to achieve. Deep breathing exercises, I go through that in length with them, and again, if they're not comfortable, they ain't going to do it, and I explain to them that they'll probably end up with a chest infection, so it's important to do those exercises as well. Before the patient goes home, I tell them that they need to keep walking. So what we don't want them to do is go home on day 4 and have a week in the bed. They're at the same risk of chest infections and thrombosis that they are in the hospital. They get patient information about wound care, walking, pain relief. We want them to keep eating and drinking. I'm struggling here because a lot of times they're talking to rooms full of colorectal nurses and we talk about bowel function, so I'm trying to stop myself asking them about their bowels as well, and they're given contact details for myself and our colorectal nurses. When a patient's gone home, they don't lose touch with me because I'm ringing them, so the poor souls never get rid of me. I ring them on day 1 after discharge, and then as often as is necessary. That might be 2 or 3 times a week. It might be never again. One lady, it was for 3 weeks because she liked to talk to me. And you know, she was on her own and that was fine. If when I ring a patient and they have a problem, so, I don't know, say their bowels haven't worked for 24 hours and they've got a lot of pain and they're worried, our colorectal nurses have a clinic every day and they'll see them straight back in that clinic. That is our way of trying to reduce readmissions through A&E, or just the patient attending A&E to be given analgesia to be sent home again. I have mithered Martin as well when I've had patients gone home whose pain relief hasn't been quite right, and he's helped me with those patients as well. The boring bit of my job is data collection. So that's one of 4 sheets of data that I collect. I actually don't mind collecting it because we use it and we change practice with it. So as much as say it's boring, we do things with the data. So 40 pieces of data that I collect, and it is shared. We have 6 monthly meetings, team meetings, where we discuss data and look at patterns and change practice accordingly. I also look at our readmission rate as well to see how many patients have come back in. The Department of Health have a enhanced recovery toolkit as well, and I also put data onto there, which is quite useful because you can benchmark yourself against other trusts and you can see that actually you're not doing very well, or I've had a few good months, so that's quite good, and it's time consuming, but it's useful to do. And I also do twice yearly patient satisfaction surveys as well, because it's all right me and the wider team thinking it's great this and we're doing a really good job. If patients think it's rubbish, we might as well stop, or at least change what we're doing and re-evaluate things. So what pain management do we use for our patients? Well, I guess when the patient comes round to me from pre-op, from the outpatients clinic, I have a good idea of the operation they're going to have, and the surgeon will write either laparoscopic or open, so I'll know. I would say that the majority, all laparotomies get epidurals. Our laparoscopic patients get PCAs. Some of our consultants like wound catheters, and one of them's had some good success recently, so he's putting more of them in because he's noticed that his patients were comfortable afterwards and not needing lots of other analgesia. A couple of them, do they all use rectus sheath blocks? Certainly 2 of them do. I think on all the patients, and we've started to use some intrathecal analgesia as well, which I'll share with you some data about that in a second. First of all, a massive problem for us that came from our data was our post-op nausea and vomiting rate. And I think Alison was sat at one of our meetings and along with our surgeons, and they all said, really, is our post-op nausea and vomiting that big a problem? As you can see, over 50% of our patients have problems with post-op nausea and vomiting, and it adds to their length of stay of up to 2 days. We looked at it a little bit more closely then and found that half of those patients had PCAs, and we wondered whether it was the PCA that was causing the post-op nausea and vomiting. So we had a plan. We thought, right, what we'll do is we'll give all the patients scopoderm patch. Came down to me to give it to the patients at pre-op, asked them to put it on the morning they came into hospital, last for 3 days, take it off and change it. Unfortunately, it didn't make any difference. We re-audited our data and post-op nausea and vomiting was still a problem. They were given antiemetics, PRN as well, but it hadn't made any difference. So we stopped the Depodur patch because it didn't make any difference. And what we have now is a bundle that Dr. Turner was talking about earlier. They click on and they're all there. And we prescribe the antiemetics for the patients, and we ask them to take them for 3 days. We haven't reaudited that yet because that's a relatively recent 6-month thing. I'll be auditing that soon, so hopefully I'll have some data and hopefully things have got better. One of the consultants said to me, how do we know it's that bad, Rach? How do you know? Well, I see them 2 or 3 times a day. I know because they're telling me. I have started to record the patients that are just nauseous against those patients that are vomiting. And I guess some of the vomiting patients go on to have ileases, so that's, you know, maybe not down to their PCA, but certainly we've changed practice a little bit. Hopefully it'll work. Depodur was one drug that became available to us. It was in the hospital, and I think Mr. Slade said, oh, I'll have a bit of that. I like the sound of that. It sounds really good. It's a one-off injection that the anaesthetist gave to the patients before they anaesthetised them. And the hope was that they'd get 48 hours of pain relief, and that actually did. I was quite surprised, but they did. So we audited 28 patients that had been given Depodur, as opposed to a previous group of 28 patients that didn't get Depodur. They were just managed with PCAs. And as you can see here, the data we thought was really good. The Depodur patients had a median length of stay of 5 days. It's only a small group of patients as opposed to 6 days for the others. But the use of their PCA was massively reduced, as you can see. The median volume was only 5 mils on the Depodur group, as opposed to 55 for the PCA group. But for us, that group of patients had 50% less post-op nausea and vomiting, and we thought, yes, we've cracked it. This is the way forward. No more Depodur, not available to us anymore. So, where do we go from here? What we're going to do? We do work closely with the pain team, and they are looking at other forms of pain relief. Intrathecal preservative-free morphine. How long does it last? 24 hours. 24 hours. Which we had a lady only the other day who had the intrathecal analgesia, and she had it on the Friday. And when I saw her on the Monday, she said, Rachel, they kept pestering me to press that button, and I didn't need to, so I didn't. I said, good. She'd had 24 hours of good pain relief from the morphine that they'd given her and was fine on paracetamol. She just must be a very strong lady. She'd had laparoscopic surgery, admittedly. She said, I did need a bit of it, but I didn't need it when they were pestering me, so I didn't press it. Should I have pressed it? And it made me realise that she didn't want to use it, but as nurses we were saying, well, you must do it because you must have pain, because what else did we give you? Maybe it hadn't been handed over that she'd had this morphine, and because it's a relatively new thing, we perhaps don't understand how much of a benefit it's going to have for these patients. As I mentioned earlier, we do use, some of our surgeons use wound catheters, and it looks like we'll probably be using more of those, and we're just going to continually to audit what we're doing with these patients, really. I just wanted to share this with you. Patient satisfaction survey, it's a little bit old now, but the blue bars are obviously the enhanced recovery patients, and the red ones are the inpatient survey, and it shows that those patients were satisfied, well, greatly satisfied really, with the whole service that they got from enhanced recovery and the benefits they felt from it. I don't know if you want me to do questions now, or should we watch the video? I've got a little DVD to show you, because it's all right me standing here and telling you how brilliant enhanced recovery is and how good we are at it. The patients are the most important thing, and we've got a little DVD that shows 3 patients' experience and how they felt about enhanced recovery.
When I went to see Mr. Harris, he said to me that you've got a tumour in your large bowel. which was quite a shock. He explained about the keyhole surgery and sort of like reassured me. And to be honest, I was worried, but not after I'd spoken to him. I couldn't believe 2.5 days to be going home. It was unbelievable. But I should have gone home on the Thursday, but they said, no, you can go home on the Wednesday. You've done very well. And that's what I did. I came home on the Wednesday. It was so easy, really. I couldn't believe how efficient and that it was. I was shocked, really. But I felt so well after the operation that I thought I'll be able to manage, I think. And after a couple of days, that was something that I didn't really worry about because I felt so good. It's better that you know what you're coming to and what to expect, and everything just was as they said. And I'm here to tell the story, aren't I? Really, so.
I had no problem coming into the hospital. I had no apprehensions because I'd been fully briefed as I wanted to know every minute detail, and they went through everything to tell me what would happen at what stage, so I had no apprehension. So I knew what to expect. Each day they came in, asked how I was going on, and then said what would happen next. So, you know, I had no qualms or anything like that. I think it was the recovery team seem to have changed how they do things, and it was more intense, you know what I mean, intense in making sure that you do well with their help. This time I knew what was going to happen, but it was a better experience, and so I think mentally that helped my body to recover quicker, and I was home in no time. I was surprised. Very, very surprised.
I had an appointment with a lady called Rachel before I came into hospital, who gave me lots of information. We had a really good chat. At the time I thought, crikey, do I need all this stuff? But when I went home and read through it, I definitely did. I felt very comfortable, and the conversation before I went in was really reassuring. To know exactly what was going to happen was terrific. I felt that all the information I got from Rachel and the team in the hospital, it was really useful to help me make a decision on exactly what I wanted. After the operation, I did feel that when Rachel came and said, right, time to get out of bed now, it was no, I'm okay in bed, thanks, I'm quite happy here. And then when I look back on everything that we talked about, and right, this is part of the advanced thing, let's get out of bed. And it was difficult, I can't lie, but I really wanted to. When I know what the end result is, to get motoring and get home and feel better quicker, it just makes total sense. But it's not always easy. When I went home, I got phone calls from Rachel daily for the first period, and I found it absolutely, totally useful because I had a bit of a dip. I was over the moon to get home and back in my own environment, but after a few days, my appetite was rubbish. And Rachel was on the phone, and she was quite strict with me that I should be eating something and making sure, otherwise I might end up back in hospital, which to me was a huge encouragement. My wife did find everything that we were given pre-op very useful. She read through it more than me, to be honest, and sort of prepped me on all that. I looked through it, but she went through it in fine detail. But afterwards, she really enjoyed the phone calls because it meant that she was able to police me a little bit better, and actually snitched on me at one point for not eating enough. And so it was quite useful to have that contact with Rachel, and for Carol to be able to keep an eye on me. One of the important things for me, being a professional musician, having a career, is that I wanted to get back to it as quickly as possible. So even all the pre-op appointments, I was counting the days and the weeks at how much time I might be missing, and I found the guys really flexible, obviously as much as they could be to fit me in, and my work were useful as well, they were good. But all the time throughout the programme I was thinking, right, is this going to help me get back to work sooner? And it did. After 8 weeks, I was back in the Symphony Orchestra playing Elgar 1 in Leeds. It's terrific.
What seems to come out on that DVD, Rachel, is the sort of personal service that patients seem to have pre-operatively and post-operatively and at home with you. What's going to happen when you progress on to the orthopaedic and gynae enhanced recovery as well? Will you be seeing those patients? Will they be getting the same personal by another enhanced recovery specialist nurse just doing that job?
We're very fortunate that our trust have bought into enhanced recovery, and we have an enhanced recovery nurse who does urology and gynae. They happen to come together because they're on the same ward. That's why she does them both. In the next few weeks, they're going to employ an orthopaedic enhanced recovery nurse, and in July, they're hoping to secure monies for an upper GI nurse. I know we're very fortunate, and when I go to other trusts, they have people that come in and set the programme up and leave it.
That's what's happening in our trust.
We went to a meeting, and there's a surgeon whose name escapes me up in Scotland, who's quite an eminent surgeon, who had his own dedicated colorectal nurse, enhanced recovery nurse, and I think she left, so they didn't re-employ anybody, and it went pear-shaped. And he said, I'm not doing this now, I want her back. So some trusts can manage without, and I'm not saying that you have to. I mean, I think you do. I think you do. But another trust can manage without. Maybe they are as successful as we are, I don't know. But for me, it's about people like Adrian and the service that we give him.
What band are your other staff in orthopaedics? And
They'll be band 6s.
Rachel, did you say that all of your lap bowel cases go to HDU?
Because if they get the intrathecal morphine, they have to go for 12 hours.
Okay.
I think you should see that our HDU is very much a surgically driven HDU, and it's not an intensive care driven HDU. So the idea is that you can provide a high amount of input to a group of patients for a very short amount of time, rather than having patients who stay on there for days and days and days. There's an overflow from intensive care. So there are a few patients like that, but the majority will be patients that are rapid turnover and going in and out of those beds.
How many patients, in your enhanced recovery pathway with the spinal morphine had the delayed respiratory depressions, after 12 hours, or salmonells, they are not.
I can say that we haven't had any, and the evidence would suggest that if you keep your dose relatively low, you won't get that. Even with the Depodur, because we knew the evidence was if you didn't go above 7.5 milligrams, you didn't get respiratory depression. We didn't use the 15 milligram dosage. So we didn't get anyone with respiratory depression, but everyone got improved pain relief. With the intrathecal morphine, then if you don't go above 0.3 milligrams of the intrathecal morphine, then you don't tend to get the problems with respiratory depression. But you may still get the itching and urinary retention and all the other problems, but everything has problems. There's nothing without.
No, but the major issue with that.
Yeah, respiratory depression, there's no difference with the